Fiscal TA webinar with Mike Geiss. I'm going to turn it over to Mike in just a few minutes, but first, some housekeeping things that you've probably heard many times before. First of all, this is Shoshana Zatz from the California Institute for Mental Health. You are all currently muted, but Mike will be pausing on a regular basis to ask for questions. If you have a question, you can just type it into the question box that you'll see on your screen, or you can click the hand icon next to your name. That will alert us to take you off mute so you can ask your question. I emailed all of the materials for today's webinar to those who registered this morning, but if you didn't get them or you weren't registered this morning and you registered subsequently, just send me in the question box your email address and I can send them to you. The webinar is being recorded and we'll post it on the CIMH website soon. When it's available, you'll receive a link to the recording. The next Small County Fiscal TA webinar is scheduled for April 7th from 3 to 4. Thank you, and I'm going to turn it over to Mike now.
Great, thank you, Shoshana. So what we're going to talk about this afternoon is what was covered at the March 6th Joint Financial Services Committee Information Technology meeting. And you can see the list of the topics there. One thing for those of you who weren't there, there were some key state staff that were out, and so a lot of issues that we usually cover were not discussed, such as the electronic fund transfer process, warrant, offsetting or green sheeting, electronic admittance device, and the inpatient managed care offset reports. So there was quite a bit that typically we talk about that was not talked about and we did not get any updates on. But so diving right into what we did talk about, we had a presentation from a representative of the Department of Health Care Service on this whole MIDA concept, which is MIDA stands for the Medicaid Information Technology Architecture. And the presentation that I just jumped into was distributed with your material today. And so if you want to dive into it, you can go through and look at the presentation. I'm not going to go through it. I think some of the key things from our perspective is that it's really a structured business process improvement initiative that ultimately results in interoperable Medicaid processes across all the programs, so we don't end up with just a siloed behavioral health system. The other thing that I think is really important to know about this is that it's not just structured toward information technology. It's all about business processes and business process improvement. Again, one of the key elements from my perspective is that really the behavioral health business process, and this is put out by CMS at the federal level, they don't want a standalone behavioral health business process or any of the business processes, and so they want those to be incorporated with all the other healthcare programs that are reimbursed under the Medicaid program. And so kind of give you an idea on some of the issues or some of the areas they're looking at or talking about. It goes from data reporting to payment to provider enrollment certification. All those sorts of things should be where it's really seamless to the outside world what that looks like within the state. And as we all know, our processes within behavioral health are very siloed within the Department of Health Care Service. So it's definitely a different sort of approach over what we've dealt with ever since behavioral health has been in the Medicaid program in California. And again, at the very high level, the way I look at this is that the MIDA kind of provides the guidance or the impetus on where we want to go in terms of a future reimbursement system. in terms of this interoperability and not being a standalone behavioral health system. It also, by following their guidelines in terms of how to, the MIDA initiative, you end up, the state will qualify for enhanced federal financial participation for the development of this process. And so what that means is that I believe the state can draw down about 90% FFP. And I'll talk about this on the next slide, but where the counties are funding some of this, it will allow significant leverage of federal dollars to help fund the development of a future system. And so, again, we went through this quite a bit. I would suggest that, you can take a look through the presentation. It might be hard to decipher without, having the presenter there. But really, if you want more information, they've got this SharePoint site, and you need to contact this Kathleen Wall. She can go ahead and send her an email and request a user ID and password to the SharePoint site, and then you can access all the documents that DHCS has put together on the MIDA process, the MIDA assessments. Again, it's significantly more than just behavioral health because it is all the Medicaid programs in California. But if you want to take a look at that, that would be the best way to kind of get a really good feel for what the process is and where the state is. So anyway, that was the first thing that we covered there. Does anybody have any questions? We also, I should say, we talked about what does meaningful use do to compare to this and some other things. And again, I think there's still a lot. I look at the MIDA as a kind of an overarching process and structure versus kind of some of the detailed stuff that maybe a meaningful use would have. But those are the things that all need to be explored. So does anybody have any questions on the MIDA? All right. And where this leads us is the next topic, which is the Short-Doyle 3 Project Management Plan overview. And if you remember, we've talked about this probably, I don't know, 6 months now, that the state is looking to the counties to fund a feasibility study for a new Short-Doyle claims processing system. And really what has happened is that has kind of morphed into this, both a short-term and a long-term plan for how to look at data reporting and reimbursement for behavioral health within the Medicaid program. And so that's kind of where that MIDA construct fits into to kind of where we're going, is that it kind of provides a high level, again, some high level guidance in terms of probably where we want to be to achieve a higher level of, I'm not sure what it's called, if it's MIDA compliance or just a higher level of MIDA. So we've got this Short-Doyle 3 project management plan that's being developed. And what you see on here are really kind of some of the short-term objectives. We're working with the Department of Health Services to construct this project management plan for a new specialty mental health reimbursement system, and really looking at some of the fiscal process restructuring associated with that. What we want to do is, so we need to draft this plan, this project management plan, and then pilot test some of the new approaches in some of the counties and kind of see how it works, see how, is it going to cause major issues in some of your data collection systems. A lot of you have done electronic health records recently that potentially would be impacted by something like this. But really, the goal of the new reimbursement system would be to more accurately estimate the Medi-Cal costs during the fiscal year, so that rather than waiting for settlement, that you would actually, throughout the fiscal year, be getting the most reimbursement or getting the most accurate level of FFP based on, at least in the short term, your certified public expenditures. We believe that currently we're probably receiving less FFP than we could because a lot of the claiming issues associated with the Short-Doyle system, both on the county side and implementing new systems, as well as on the state side and in some of the changing business rules. So this approach would potentially or would hopefully result in more accurate estimates or determinations of your FFP, probably on a quarterly basis. We'd probably look at moving away from the HCPC codes and go to CPT codes, and basically eliminating the mode and service function codes. Obviously, that would impact the cost report and potentially some of the data system changes that may be associated with that. So the whole goal of this pilot would be to see, okay, if we want to go with this new system, what sort of changes would that entail? How difficult would it be on the counties? And ultimately, what would some of the costs be associated with those changes? Because we may find that in the short term, it's not worth it to do such an approach because the costs are just too great. And then in terms of the long term, and I really don't have anything on here on the long term, but with reimbursement, we're looking more towards a capitation or case rate system. And again, in developing those, you need the best and the most accurate costs data to figure out what should the case rates and capitation rates be. And we don't believe we can get that out of our current system. So that's more of a long-term goal, and how the short-term kind of feeds into the long-term goal. The other part is on data reporting. We don't think that probably long-term that there would be a siloed behavioral health Short-Doyle reporting system that ultimately, if we are capitation or case rated, it would be more consistent with a health plan data reporting. And so we'd probably start to get into the same sort of data reporting as the health plans, and that would help to eliminate one of the silos. And really, long-term, the goal of this is to help DHCS achieve a higher level of MIDA in more operability, also help your ability to communicate with the other healthcare players, the health plans primarily, so that we can all talk to each other. And again, so that it, from the outside, from the patient or client's perspective, it's seamless and it doesn't, they don't see these different systems. And so in terms of this project management plan and this pilot is what is being initially funded, or one of the things that's initially funded with the money that you've been asked to give to Cal Mesa, who is managing the process, and there's Sarah's email if you need to contact her. And they're going to, it sounds like, be doing another call fairly shortly, as well as Sarah, it sounds like, is available to the extent you need any sort of questions answered or additional support in how to present this to either your boards or your stakeholders. And so I kind of talked through the short and long-term strategies. And the other part of what will be funded with that Cal Mesa money are enhancements to the Short-Doyle 2 system. So that system is going to be around a little bit. And so the SWAT team is developing a list of those areas and those system changes that need to occur, and they will prioritize those, and then basically you guys will be paying for those system changes to the Short-Doyle 2 system. One other thing that came up during this discussion was some of these questions that were raised, like again about the meaningful use. And so we need, we being CMHDA and Cal Mesa, need to figure out a way to capture those questions so that they can be tested as part of the pilot approach, and make sure that we get answers to everything, so that before we say, hey, you know, this will work, that we've fully vetted it and analyzed all the impacts. Anybody have any questions on that? And again, I think the soonest we'd be looking at a different reimbursement system would be fiscal year 15-16. So with the assumption that we can do the pilots probably later this summer and just see how it works with some counties. All right, if there's no questions, we can jump into some of the Short-Doyle 2 updates. Here we talked a little bit about KDA implementation, and most of these updates came from the SWAT team. And so apparently DHCS has approved modifications to the Short-Doyle system that will allow multiple modifiers to be submitted on the same claim, and that just needs to get scheduled so that the system changes can be implemented and so that you can do that. The ICD-10 implementation we talked a little bit about, and I'm a little fuzzy on this, but it sounded like there's a October 1st implementation deadline, and the state intends to meet that with the ICD-10. However, DSM-5 is not part of that and probably won't be implemented until much later. And I wasn't sure. I thought he said 2017, but maybe it was 2027. So anyway, nothing on the current horizon. We talked about the CPT code changes, and really what this is mapping the HCPC codes to CPT codes or vice versa. And the SWAT had submitted a list of recommended crosswalk to State Department of Healthcare Services. They apparently are still reviewing that crosswalk and haven't gotten back to the SWAT team yet. And then we talked about the Medicare Advantage Plan claiming, and again, this is something I think we talked about in the last call, where they did issue an information notice for mental health that describes the process for obtaining certification so that you don't have to bill Medicare before billing Medi-Cal for certain services that are not covered by various Medicare Advantage plans. However, where we talked about it this meeting had more to do with the drug Medi-Cal program, and that approach does not apply to drug Medi-Cal, and they're still trying to figure out how to make or how to apply a process to the drug Medi-Cal services so that you don't have to bill the Medicare Advantage plans for drug Medi-Cal services. Anybody have any questions on any of those issues? All right. Then we spent quite a bit of time talking about these denial reason codes on the 835 files. So apparently there were HIPAA required changes that needed to be implemented on January 1st. Really this has to do with developing uniform denial reason codes across all systems. In the meeting, it sounded like DHCS knew about this back in July, but really didn't inform the counties until January, and that was through this information notice here that we distributed, 1401, that talks about, and actually this provides you the background and everything else in terms of why they're doing it. But they are changing some of these codes, and the list, I don't know if this is a full list, but this was part of the information notice, and so they are making these changes for the not denied reason codes when you get back your 835 file. Apparently these changes became effective last Friday. They were going to shut down the ability to submit claims, I believe, until noon today while they made those changes. The main change is that a bunch of the denial codes are being consolidated into one code, which is going to make it more difficult for you to understand why something is being denied. And for those of you that have contract providers, to try to ask your contract providers to, make the changes and resubmit claims, it's going to be more difficult. What the counties had asked for is a delay in implementing this, not doing it last Friday, but let's take a look at this a little bit closer, because there were some codes that are being changed that it didn't sound like needed to be changed. But DHCS said they were going to incur penalties if they did not make these changes. So I didn't look today, but I assume that these changes were made and implemented. It does not impact replacement and void claims. And then the counties did request that the state provide the denial code listing for all the denial codes so that we understand what we're working with. So again, I would suggest referring to this info notice, and to the extent you have other questions, you're probably going to want to contact MedCCC. And I can try to answer any questions, but I'm probably not going to be real good at doing that. So then we moved on into the claims payment update. And so we talked a little bit about the 910 cost report settlement. And they're a little bit behind. Last month we thought they were going to issue these early March, but it sounds like it's going to be more late March. And as of last Thursday, or at least when the state reported out, they had received 43 of the reconciled cost reports. And so those are the letters for those cost reports should be ready to go here in a couple weeks. And you guys will get the settlement letters, and it'll tell you whether you owe or whether they owe you funding. The 1011 cost report settlement, they're getting ready to lock down the cost reports. As most of you know, once it goes into the reconciliation process, you can no longer make changes to the cost report. And here again, they thought they were going to go ahead and have those reconciliation letters out by the end of this month, which should give you, if you do a pretty quick turnaround on your reconciliation, you may actually be able to, if the state owes you money, get the funding by the end of this fiscal year, but you probably have to hustle on that to try to get that done. And so that's the 1011 cost report. Then we talked a little bit about state hospital bed payments. And so the state department, or the Department of State Hospitals for 14-15 is looking at using a two-rate structure, a rate for the acute intermediate level of care and then for the SNF level of care. And probably the main reason I think we were talking about the state hospital bed payments was that the Department of State Hospitals has identified approximately 10 counties that they underbilled, and they said it was around $10 million. And so they're going to be doing a reconciliation with those counties. They didn't list who the counties are, but apparently they will be contacting the counties to do the reconciliation. But one thing you want to be careful of is you do want to look at the accuracy of whatever data you get from them and verify it against your system to make sure that it is in fact accurate if you're one of these counties that has the reconciliation. And then the final thing we talked about on the state hospital bid payments is that it sounds like they do intend to move to cost-based rates by fiscal year 15-16. And so again, this is typically where we would have had a bunch of other things to talk about under the claims payment update, but the folks weren't there, so we didn't get into it. But does anybody have any questions on this stuff?
There's a question going back a few slides about, you said that the DSM-5 was going to be implemented in 2015 or 2017, and the question is, was that a fact or were you just projecting that?
No, I thought, so DSM-5, I mean, the key that I got out of it, it was much later. It's either, and I wrote down 2017, but then I thought he said 2027, so I didn't hear it real well, but I think we're looking at least 3 years, or it's 13 years, but I can't imagine it's 13. That's why I'm not sure what the date is, but it's not anything that's going to happen this October 1st, like the ICD-10. And I do believe the state, although it's a little old, they have an info notice indicating that they don't intend to address DSM-5 for a while. But I don't believe that had a date on it either.
Someone just wrote in and says, what they said is that DSM-5 is more closely aligned with ICD-11, which is not coming out for a while.
There we go. All right, any other questions? All right, moving to the MHSA update. The only thing we had here was this, the work that has been going on with the revenue and expenditure report. And you'll hopefully remember last month DHS agreed to look at the 1112 format. And so they asked for some input from CMHDA, and we recommended using the cost report workgroup, the CMHDA cost report workgroup, to look at that. And so that has been going on. We've had a couple of calls, seen a couple of different drafts of a revised 1112 revenue and expenditure report template. And I think they're getting pretty close to issuing that through an information notice. And just to kind of give you an idea, that I think one of their main goals, at least with with any changes to the 1112, was not to make so many changes that they couldn't use the forms that were already submitted by counties. So really all they're changing is the unspent funds worksheet, and they're not changing the component pages at all. They also, as part of that, were eliminating the reversion calculation on the unspent funds pages. At least in the last version I saw they did, which I think is where we had some of the major issues, because we didn't necessarily agree with the calculation. And again, I think one of the keys is that counties that had already submitted the 1112 revenue and expenditure report, you're not going to have to resubmit or re-enter data into the new template. You can just leave the template that you submitted or the report that you submitted intact. And then they said once they issue this info notice that counties would have a couple of weeks, 2 to 3 weeks, to complete the 1112 and get it back to the state. But again, hopefully the changes that this work group has been discussing, they're not perfect, but at least hopefully they'll be enough to at least let you submit the 1112 format, completed with that unspent funds page, again with no funds showing as reverted. The work group's going to continue to meet because, like I said, this isn't perfect, but it's at least a little bit better. And kind of where we still see some of the areas that that might warrant additional changes are, they're constantly trying to tie out the prior year report to the one that you're submitting in terms of the unspent funds. And as we've raised numerous times, there often are changes between when you submitted the report to when you're now filing the next year's report, primarily in the Medi-Cal area, for revenues associated with a given fiscal year that were probably estimated. So we'll see how that can potentially be resolved, hopefully as part of the 1213 template. Also, whether either whether we need the 1995, the MH 1995 on the cost report, or how is that supposed to tie to the revenue and expenditure report. It seems at this point somewhat duplicative, as well as causes confusion, I think, among some of the auditors. So we'll probably be talking more about that. And then finally start to talk about what they're thinking in terms of a reversion policy. How are they looking at handling, for example, interest and FFP, and then also the PEI prudent reserve, which it sounds like the state is willing to potentially change statute in order to make that clearer, so that you can put PEI funds into the prudent reserve. But in any case, the 1213 template probably won't be out, I would think, for a while, until these other issues can be resolved. Anybody have any questions on the MHSA stuff?
There was a question, which I think you just addressed, about whether there's an update on the PEI funds going into the prudent reserve.
Yeah, I think they're still working on it, and it sounds like that from DHCS's perspective, and I kind of somewhat took this as positive, that they agree that the language in the statute is vague, and so that's why they wanted to modify the statute to try to clarify it. But that said, I'm not sure if they're going to say, well, that they can go back and allow it. So I don't know if that's going to end up being more difficult and result in. Bottom line is, I think they want to make it work, and it's just a matter of whether they feel they can going retroactive, and we think that they can because of the vague language. The other thing is, if that is one of your issues, then when the 1112 template comes back out, contact DHCS. And apparently what they've been allowing is some counties to open up, or they've been opening up the cells for the counties to allow them to populate and show the PEI funds going to the prudent reserve. So once we see the final 1112 template, hopefully the info notice would, I don't know if it would be that specific, but we would definitely ask if that is still a possibility, or should counties do that until the policy issue gets resolved. And again, to a certain extent, by taking reversion out of the form itself, it still matters, because your prudent reserve the balance isn't going to be accurate, but it might not be as much of an issue, because your funds aren't showing as reverting if you don't have them dedicated to a prudent reserve on the form. It would just be part of your unspent funds. All right, moving on to the state and federal budget update. There's about, so the 1991 mental health realignment growth, there's a little bit, there's 5% of the growth in the support services account on the 2011 side that goes and funds kind of one-time payments or one-time growth in the 12-13-19 or in the 1991 mental health realignment account. In 12-13, that was $10.7 million. That still remains to be allocated by the State Controller's Office. CMHDA and then CSAC has recommended using the current allocation percentages for the 1991 mental health realignment as the percentages to allocate that $10.7 million. So if you want to see what those percentages are, you can click on that link and calculate your percentage as a percentage of the total, and that would be roughly your share of the $10.7 million once the State Controller's Office is ready to allocate that. And I think we do anticipate that happening before the end of this fiscal year. And again, it's just kind of like a one-time payment that you get based on the way the 2011 realignment was written. And then we talked about the 2012-13 behavioral health growth amount in the behavioral health subaccount. There's 27.8 million. CMHDA and I believe CSAC had initially said, it's not enough to cover the growth in those entitlement programs, so go ahead and just push the money out using the existing percentages. But it's become clear that DHCS is looking at using the 1213 approved claims for determining the growth allocation to each county. And I think if I remember correctly, they're using the claims through December. So they may or may not have all the claims, as well as the claims are based on interim rates. So CMHDA has always taken the position that that the claims data isn't necessarily the best amount to use for this purpose. But kind of basically the bottom line is that everybody's still meeting on this, and it has not been resolved, and it won't be resolved this month according to the state representatives, which kind of starts to put it into question when this little bit of growth will be pushed out to you folks. And then we talked a little bit about the 1314 behavioral health subaccount allocation percentages. If you remember, in 1213, the state had issued an information notice that showed how the amounts or the percentages were determined for each county, and it showed it by program, so it allowed counties to allocate their distributions to the different programs. Apparently they're pretty close to publishing that for 1314. And really the only part that they're waiting on is, I guess, a review from the Department of Finance. Anybody have any questions on any of that?
There's a question about how do we determine our percentage for fiscal year 12-13, 1991 mental health realignment growth?
Yeah, so you click on the link there under the first bullet, the third sub-bullet under the first bullet on the state controller's website, and I wonder if this will let me do it. I don't want to start trying to do that, but if you go in there, you'll see that you'll see how much you get on a monthly basis, and it's actually the same amount every month. And so you just take your amount and divide it by the total distributed to all counties, and that's your percentage. But they don't have percentages, they just have dollars, and you have to compute the percentage by dividing your amount by the total amount. All right, then we talked a little bit about the 1415 behavioral health subaccount allocation percentages, and it sounds like they're working on an allocation schedule. And what's a little bit concerning is that they said they're working on it in conjunction with the 1213 growth for the behavioral health subaccount. So I'm not totally sure what that means. If it means that they're going to try to use the 1213 approved claims and totally rebase everybody, or if they're just going to add the growth onto the 1314 amounts to come up with the 1415 percentages. But in any case, they said they're working on it. They still have a ways to go. They intend to post an information notice that describes how they came up with those percentages prior to the start of fiscal year 14-15. So obviously we'll keep our eye on that to see what they're going to recommend. Now, the statute itself, I believe, says CSAC is supposed to submit a recommendation, and I believe they have through, based on what both CMHDA and CADPAC came up with, which basically said that 1314 is kind of a base amount and nobody should be adversely impacted. The problem with, I believe, the statute is that it says that CSAC submits a recommendation. The state may or may not accept that recommendation and can kind of do their own thing, I believe. So at this point, it's kind of a little bit in flux, but until we know more information from what DHCS is going to propose. And I should say, I think it's beyond just DHCS. It's probably the agency level over at the state. And then we finished off this by talking a little bit about the 1991 realignment reporting to the State Controller's Office. Up until the beginning of this fiscal year, you had been submitting quarterly reports to the State Controller's Office and making certain certifications with regards to the placement of funds in the Health and Welfare Trust account, and I think more importantly that you have contributed your required maintenance of effort for the 1991 realignment into that account as well. And so the State Controller Office, with a lot of the changes in the 91 realignment, primarily on the health side, discontinued that report. And it sounds like they're about to issue a different format or different report that you will use to report on your 1991 realignment. And so hopefully that will come out soon. And really where that comes into play for you who are part or who end up well, you all end up audited as part of your triannual mental health plan audit. The state looks to that support a lot of times for the justification that you complied with meeting the maintenance of effort requirement and depositing it correctly. Anybody have any questions on those things? All right. And we got a little bit into the work group updates. It sounds like the fiscal state plan amendment is getting really, really close. DHCS received comments from CMS in late February, and it sounded like the comments were not that substantive. And so the DHCS believes they'll formally submit or officially submit the fiscal SPA in March, and that would then give CMS 90 days to review and respond. Hopefully they wouldn't take that long, since the state has worked with them closely and informally to try to get all the issues resolved. It hopefully will go through fairly easily. The one somewhat wrinkle to this is this whole customary charge issue, which we've raised for actually quite a while, but the state is finally agreeing with us, it sounds like, that the customary charge would not apply to the counties as government entities. And there's provisions in the provider reimbursement manual that allow for that. So they're going to have to incorporate this into the state plan amendment in order to make it retroactive back to January 1st, 2009. And so that could cause a little bit of wrinkle if CMS disagrees with that approach, although I think I would find it hard to believe that they would, given the way that the provider reimbursement manual calls it out pretty specifically. But it may slow down the process a little bit. Ultimately, this, I think, is good news for us, because it means that you will be reimbursed your actual costs for county-operated providers, and that would be retroactive back to the implementation of this state plan amendment, which goes back to January 1st, 2009. DHCS, because the other part of this fiscal SPA that's important to you is the ability to get FFP for costs that you incurred above the SMAs. And so DHCS has, I guess, worked out a process for doing that. Once they formally submit the SPA for review, it sounded like they would go ahead and start to implement that process for you to submit a supplemental claim, probably a one-pager based on your most recently either filed or audited cost report in order to obtain the additional FFP. So that's all sounding fairly positive. Then we talked a little bit about, or I should say DHCS mentioned that they're looking for some feedback on what sort of content and type of cost report training you want for next fiscal year. I believe some counties have reached out to the state and volunteered for a work group. And so hopefully that training will start to come together for 13-14, for the actual 13-14 template. All right, anybody have any questions on that?
There's a question. Will this be a final determination that we are not subject to customary charge going forward?
As long as this state plan is in effect, yes. So it would, yes, it would be until the state plan changes, which, again, ultimately it probably will change as part of moving to case rates or capitation, but as long as we're in the current sort of reimbursement system, once it's approved and in the state plan, we should be good. All right. We talked a little bit about some issues around the drug Medi-Cal program. And part of this had to do with clarifying the issue that we talked about last month, which had to do with the Medi-Cal claims processing and just what the state's going to do for some of the expanded services. And so really the state doesn't have CMS's approval yet to implement some of the expanded services for these ones up here, the intensive outpatient treatment and the new non-perinatal residential services. So that's all pending CMS approval. And they also need to amend your contracts to incorporate these services, as well as incorporate county oversight, authorization process, update the rates, and probably look to at some point incorporating a UR reimbursement process similar to what you do under especially mental health. And really, so they issued this notice saying that any of the claims that contain a claim file that contains a service associated with a state general fund payment, they'll process the claim, but they won't pay the claim. In fact, they won't pay anything on the claim because of the issues I just mentioned. And then they say that if a claim just has FFP, they will go ahead and process those for payment. And then, again, this is only for services beginning January 1st, 2014. Now, it was somewhat interesting, and I wasn't real clear. So they've issued this notice fairly recently on March 4th, but it sounded like folks were saying that this wasn't what they were told or what is happening at the state. So I'm not sure about that, but I think this is pretty clear in terms of what they're doing with the claims and with payments. And so once the SPA gets approved and the contracts get amended and signed, then they would pay those claims that have a state general fund share associated with them. The other thing that came up when we were talking about drug Medi-Cal was somebody mentioned they thought there was going to be a change to the cost report. And I think there might be. Well, actually, I should say I don't know. I would think some of these things by themselves would warrant some change, but nobody there knew specifically whether there was going to be a change to the cost report and what that cost report would look like. I guess the state continues to maintain on the drug Medi-Cal side that they're not going to do any more training other than how to enter data into the form. So unlike especially mental health side, where they're at least taking input into what we'd like to see in training, it sounds like they're not going to really provide much training on the cost report. Anybody else have anything on this page? All right, and then just moving, when we got into county to county, we talked a little bit about the coverage expansion, and this is primarily around developing an 1115 demonstration waiver for drug Medi-Cal. And so what that would entail, it's more voluntary participation on the part of the counties in a demonstration waiver versus the 1915B waiver that we have that is not a demonstration waiver that everybody has to do on especially mental health side. But some of the aspects that we're talking about as part of the waiver would be a closed network where you would have the authority over the providers. We also talked about whether using CPTs, certified public expenditures, CPE, versus using intergovernmental transfers as part of the reimbursement process. What some of the rates might look like, and so a lot of this is really just in preliminary stages. And I think the goal is to bring some of the fiscal issues back to the Financial Services Committee as they arise. There's also, a bunch of statutory cleanup that needs to occur as part of this to hopefully take out a lot of the state-only type of things and focus more on federal requirements. And then the other part that we talked about under coverage expansion, many of you have probably been contacted by the health plan or the health plan's representatives because they're required to provide mental health services to the mild and moderate mentally ill. And so they need to ensure they've got a sufficient network. And so some of you are being contacted, and we didn't get too much into that. But at some point, we're probably going to have to talk about that in more detail in terms of how to report some of that, both in terms of the cost report, CSI, Short-Doyle system, all that sort of stuff. We talked a little bit about audits. There were a couple of issues raised to just kind of as a heads up. In the fiscal year 08-09 audits, the auditors did not include one of the enhanced aid codes, which is 8P, and the county caught that the auditors were not including the services provided to beneficiaries with that aid code, and was able to hopefully change the audit finding. And so we talked a little bit about how do you get that level of detail from the auditors, and you can request it that they provide the supporting claim line by claim line detail for how they came up with their units of service that they're saying are the state's system, but oftentimes they won't work with you until you get into the appeal process, and then they won't have a choice but to help you out and provide that data. But it also means that you have to have the ability to look at the data both on their end and your end to identify where they may have some gaps. And then we also found out that some auditors on the MH1979, which really comes from the MH1900 info page, where they were using, the auditors were using 50% of your managed care offset as your inpatient amount, which is not appropriate for 8, 9, 9, 10, 10, 11 when we had an enhanced FMAP. It should be grossed up by whatever the FMAP was in place at that time, which would give you a higher administrative reimbursement limit at the 15%. So again, just kind of pay attention to that if you see them try to make adjustments to your MH1979. And then it was brought up or requested that CMHDA look into forming a audit subcommittee or a work group. And I would suggest emailing Don Kingdon if you'd like to participate in that, because that's a good way. Maybe this work group will kind of focus on some of the audit issues and bring it back to financial services as various issues are identified. And then on the Medi-Cal administrative activities discount percentage, the auditors had started applying basically just what percent of your county population was on Medi-Cal, and they were saying that's the discount percentage that you needed to apply for MA. They have subsequently backed off of that pending a state plan amendment approval from CMS that would allow you to rely more on either probably more on unduplicated clients or units of service or caseload for the folks that really are more apt to seek out especially mental health services versus the entire population of a county. So that was good news, and we'll probably hear more on that as a state plan, I believe, has been proposed, an amendment has been proposed, and if that gets approved. And we talked a little bit about the LIP payments. This is the Low-Income Health Program that ended on December 31st, and apparently most counties have not received any payments for mental health services, and we're not sure whether the claiming protocol that we had proposed ultimately ever got approved. And so I'm assuming we'll continue to hear more about this, especially from the larger counties, because it's pretty significant payments for them. And then again, we talked a little bit about the PEI Prudent Reserve, really nothing more than what I covered earlier, which is that DHCS is looking to change the statute to more clearly allow for PEI funds to be dedicated to the Prudent Reserve. And so we look forward to that and that clarification so that we aren't in this gray area anymore. And that was all I had. So any other questions, comments?
There are a couple of questions. In regards to the audit, this is why we need some way to reconcile our units before we get to audit. I have requested a unit-approved report from the state, and I'm not sure my request was heard. I would encourage everyone to push for this information.
Yeah, no, that's definitely the case. And again, unfortunately, you might have to do it through the audit's appeal process to try to get it. But you definitely, especially for you small counties, where you probably have the capability to look at, because the data is not that huge, you have the ability to look at it fairly closely and confirm that, in fact, the state's data is the same as yours.
One more question. Any MHSA budget updates?
We didn't talk about any, and I don't have anything new. Probably the biggest thing, well, actually, let's see. The February payment came in a little bit less than last year, so I think the estimates that we provided last month are still pretty much on target for the current year. I haven't seen the annual adjustment documentation letter that the state's supposed to put out the first part of March, and I'll be following up with CMHDA to see if we can't track that down, because that'll be critical for identifying what next year's revenues are going to be. So basically what we talked about last month at this point is probably as good as anything. All right, so if that is it, we're coming up right on 4 o'clock. So thank you very much, and we'll be talking to you all soon next month. Thanks.
Very much, Mike.
Bye-bye.
Thanks, everyone.